today, Dr. Daco and Dr. Moraz. So we will get started. I think Dr. Moraz is here in the panelists. So we can get started. Please, if you have any questions, just like how we've been doing in the previous lectures, put them in the chat, and after the lectures, we will do Q&A sessions. And I will be sending out the survey about midway through, so please respond to them for attendance. Thank you.
Okay, good morning. So first of all, thanks for having me. It's my pleasure to present today and to present on AI for this group of people. I will start sharing my screen. I just sent a request. Would you mind allowing me to share the screen, please? There we go. Can you see my full slides now?
Yes.
Okay, so good morning. My name is Fabio Moraes. I'm an associate professor, Division of Radiation Oncology at Queen's University in Kingston, Ontario, Canada. And I'm also director for our global oncology and also a visiting professor at the University of São Paulo. I'll be presenting today the first half of this webinar and then a part of the course, and then Dr. Farouk will do the second half of the lecture today. So first, my disclosures. I am a believer. I believe in technology. Other than that, I have no other conflicts of interest to report. So the learning objectives today is to understand fundamental concepts of digital transformation and artificial intelligence in oncology and medical education, discuss the benefits and limitation of AI in global oncology, and explore the impact of AI on medical training and medical education. So let's start by digital transformation. So digital transformation, or DT, refers to the integration of digital technology into various aspects of healthcare, delivery, and research, fundamentally changing how we operate and how we deliver care. It's also a cultural change, and that happens over time. We don't get comfortable to things until we test for a long time. Healthcare always has suffered with digital transformation because things takes longer in healthcare. However, the COVID pandemic accelerated digital transformation across health systems worldwide. There was a rapid shift on adoption of digital technology, including telemedicine, including chatbots, including electronic medical system. So we now are facing a revolution in healthcare, but yet we have a lot of challenges ahead of us. Digital transformation is everywhere. And once a new digital tools are introduced, you cannot put the gene back in the bottle. So that makes very important for us to understand that digital transformation is irreversible and it's everywhere, and we need to understand how it works and how it plays a role in our daily activities. And why this matters because digital transformation and artificial intelligence in 2025 is a survival issue. Our organization needs to adapt quickly to new roles, changes of disruptions, market pressure, new roles, changes, and expectations. We already are experienced that in our daily basis. Now we experience conference in a different way, how we share knowledge, how we deliver care, how we see patients, assess patients, how we do drug discovery and predictions. And why this matter for us? This matter for us because we have the assumption that in healthcare, healthcare professionals with good intentions will provide care that is high quality, safe, cost effective, through diligent work, constant vigilance, and application of evidence. However, there is lack of accuracy and precision in medicine, and that can lead to numerous challenges, including provision of care with low value. So we need to move from low precision and low accuracy to high precision and high accuracy. But we still have struggles on our health system, majorly because healthcare professionals are mentally and physically overwhelmed. We cannot keep with the amount of medical literature that is published. So for instance, about 2 million new articles per year, the doubling time of the medical knowledge moved from 50 years in 1950 to 72 days in 2020. And that makes our life harder. In addition to that, there is a growth number of new patients and the impact that patients have on our clinic activities, making difficult for us to translate all the new science, all the new discoveries to clinical care and to impact our patients. And why this is important for oncology? Because in oncology, we face many challenges, including complexity, poor data, rapid changing guidelines, and we need a recalibrated approach. We need an approach in oncology that is focused on the patient, so it's patient evidence-based centered care, and we need to provide access to new technologies and equitable cancer care. The priorities should be precision and accuracy, improve outcomes that matters, like quality of life and survival, support accessibility, ensure that treatments are available to all patients, while making sense that we need to ensure ethical and correct use of AI and digital tools in our daily activities. And what are some potential benefits of artificial intelligence for oncology? Number one, we can use for enhanced diagnostic, so help us with early detection through advanced pattern recognition, personalized treatment, tailored treatments for each patient, and also predict treatment response and potential side effects. I think the most important these days is streamlined workflows, automated or routine tasks, freeing up time from health professionals, research advancements, analyze large data sets for new insights into cancer biology and drug discovery, and finally, patient monitoring, continuous monitoring of patient health through wearable devices and AI analysis. So AI can boost accuracy and personalized treatment at a large scale. However, we still face a lot of limitations, and we can start with some of those. First is the black box problem. There is still lack of transparency in AI decision-making process. Two, job security concerns. There is uncertainty about future roles and responsibility which make people scared. Three, accuracy benchmarks. So we still have double standards for performances and expectations between humans and AI. We need to set clear benchmarkers that we can compare AI against humans or compare AI plus humans against humans. And finally, human relevance. What tasks will remain relevant in the future if AI takes over many functions? A lot of people are concerned, are afraid, and they don't want to engage with technology because they fear losing their jobs or their fears for their future. However, we need to remember that the goal with technology and with artificial intelligence is to create value. And I believe that AI can significantly support our efforts, especially as we learn how to leverage its capabilities in the oncology field. So now that we got this introduction, let's go and dive deep in an overview of AI. So what AI means? So AI encompasses algorithm that learns patterns from data. Machine learning is a subset where models improves performance with experiences. Deep learning is a subfield of machine learning, and generative AI is a subfield or a subset of deep learning that generate new content, whatever it is imaging, text, music, or other types of data. We also have many other terminologies that for people who are on this field, it's important to understand. For instance, as I said, deep learning, it's a multi-layer neural network. Multi-model, multi-integrated models are models that integrate imaging, task genomics, LLMs, generate human-like outputs, and etc. And then if we go for more in detail, floating points operation per second, it's a measure of computer performance, particularly in the fields that require extensive numerical calculation as deep learning, scientific computing, and complex simulation. And why I bring like flops? Because flops are super important. So the floating point operation, because deep learning models, they require substantial computer power due to the large number of calculations needed during training and inference. And high flops rate indicates the ability of the computer to handle this extensive computation efficiently. And that's what we learned in the last couple of years, is how to improve our flops. That way we can now do more complex tasks, sorry. And then when we look at multimodal AIs, there's now new data showing that we can integrate with this new computer technology things like radiology data, pathology data, clinical data for a more holistic assessment of patient. And in that way, we'll be able to better define problems and to better bring solutions. We also saw the explosion in the recent years of large language models. Large language models such as ChatGPT have shows promise in drafting clinical notes, understanding clinical notes, summarizing clinical notes, and helping with patient documentation or even communication with patient. But still there's some concerns because there's also risk of hallucination, and we are not always 100% confident on the output, if the output is correct or not. So there's a lot for us to learn and a lot for us to fine tune here, so we can have access to better tools on our daily activities. So I'm pretty sure that all of you have heard and are using some LLMs such as ChatGPT. So there are some current limitations regarding accuracy, coherency, transparency, and ethics behind the use. So we are still not allowed to use ChatGPT for clinical notes due to privacy of patient information, or for peer reviewing medical articles. So we cannot be using these tools because they do not protect the information. Number two, opportunities for development. So there's a lot of opportunities for fine-tuning LLM for medical tasks. There's potential for developing new architectures, validation, and also creating new reporting systems. At this point, we have many potential applications such as clinic, research, and educational. So we need to keep that in mind, that LLM has the potential to change the way that we do medical care and we provide medical care. For example, if you boost and you combine LLM with evidence-based peer review guidelines, you can create high-level medical information that is curated by artificial intelligence and also physicians, that will give you the opportunity to provide decision support system to patients. And for us that we are on the oncology field, if you weren't at ASCO 2025, you might have missed, but ASCO has launched a partnership with Google Gemini. It's a LLM from Google, where Google Gemini can search all ASCO guidelines and work as the decision support system for oncologists across the globe. So ASCO is already ahead of the game, and they're working with big companies like Google to develop the future of clinical decision-making support systems. Okay, but how that fits in global oncology? So in my view, it's not the strongest of the species that survival, not the most intelligent, is the one that is most adaptable to change. So we are now in an era that we all need to learn these new tools. We all need to learn how to apply these new tools so we can adapt and survive for as long as we can. As you all know, WHO estimate a growth in the new cases of cancer when we compare 2022 to 2045, with a disproportionate increase in low and middle income countries of incidence and also death related to cancer. The local burden of cancer is massive and it's growing, especially in low and middle income country. Technology will make this gap even more visible, make it undeniable, and make the result of our inaction predictable. So we need to bend the knee of technology to bring urgency to the impact. So that's one of the key points that you need to remember from this lecture. And how we can apply AI in resource poor healthcare system to help us with some challenges and some problems. So for instance, on this article published by Hosny in Arts and at Science, if you look here on the left, on the red box, we have some problems like access to care, workforce, equipment, limited access to drugs, and data collection. So we can use AI to help, and AI as a clinical decision tool, AI helping us with low-cost devices to collect data from patients, and also AI to learn from data and also help us with the cause effect, helping us to impact in policy making. We still have some challenges like AI literacy, so we need to educate people. AI talent, we need to support local talents to stay and help develop in the future. Regulation, funding, and infrastructure. So infrastructure is also a big problem, such as electricity, internet, and data digitalization. I'm from Brazil. I was born and raised in Brazil, and I was in Brazil until I was like 26 years of age, and I can definitely see that even if the best AI tool or the best AI algorithm is available, most of the country does not have stable internet or does not have stable electricity, making it hard for us to deploy any new technology in the countryside or northeast or north area of the country. So the key priorities for us to be successful and to build on those challenges is to work as global institutions. And when we work as global institutions, there's key points that needs to be addressed. So one is making sure that we have data and analytic governance. We invest in modernized data and analytic infrastructure. We address the skill gaps in the workforce. We develop strategies, strategic collaborative partnerships. We use good AI practices for transparency and reproducibility, and we explicitly take in consideration equity and bias. With that in mind, I'm gonna give you some real life example on how AI can touch our daily activities. First, this is a prospective study, a multicentric trial with 278 samples. And this is for especially for places that you don't have available neuropathologists. So we all know how challenging it is when you need pathology diagnosis so you can confirm your hypothesis, so you can give the best surgical approach to that patient. So this deep learning system was applied for brain tumor intraoperative diagnosis, and that was compared by the regular H&E staining pathology pipeline. So AI was able to do the diagnosis in 150 seconds compared to 30 minutes on the human side. Accuracy was 94.6 for AI, 93.9 for human base. What that tells us, it tells us the story that potentially this algorithm could help us in areas where we don't have humans and we don't have access to pathology. So we can have here accurate and fast diagnosis to help our surgeons during surgery. Second, on this paper that our team, together with multiple other colleagues, we applied federated learning across 71 sites to improve glioblastoma, one of the most important brain tumors diagnosis and delineation. So we look over 6,300 patients on a federated learning exercise, and we were able to show a 33% delineation improvement of the surgical cavity, and also a 23% improvement on on the complete tumor stent with AI trained on a federated learning setting. This approach actually showed to us that we can use diverse data sets, we can ensure meaningful results, and we can facilitate further analysis on glioblastoma and make it easier for us to have more collaborative models. So showing to us that potentially federated learning and collaboration can make the application and development of AI easier and better. Another important study is this study by Lin, published at Radiology 2019, that demonstrated that AI for contouring reduced planning time and also reduced variation. So if you can see on the left was manual contours by physicians, and on the right, AI assisted. So the AI assisted helped to reduce inter-observer variation by 2 folds, and there was a reduction in 54% in the volume coefficient. We also learned from that study that AI also improve contouring accuracy for 7 out of the 8 radiation specialists, and also reduce contouring time from 30 to 18 minutes. So what that means is like we are contouring target better, which might translate to better local control, fewer geographic missing, and less toxicity. We are also saving people's time, 30 minutes to 18 minutes, and we are also increasing accuracy between physicians. Another important point is auto-planning. So auto-planning is automated treatment that can impact on the care of the patient. So this is a prospective study from Toronto, Canada, that deployed and evaluated a machine learning algorithm for auto-planning prostate cancer. So what they show is that they could reduce RT radiation therapy planning process by 60%, and they reduced the mean time of planning from 90 minutes to 36 minutes. So saving people's time, making more people available to do other tasks, and potentially freeing up time for more patients to be treated or to be assessed. Another important study is a study that we are completing here at Queen's. It's a study that we are using radiomic features to train a model for brain metastasis development and survival. At this point, based on stage 3 lung cancer or stage 3 breast cancer, our model is producing an accurate model that can predict survival in 85% of the time and predict development of brain metastasis in about 80% of the time. Why brain metastasis? Because in most of the times, brain metastasis is very challenging to treat, and when patient develop a brain metastasis, it's hard for us to provide any curative approach. So that's like why we are focusing on this population. Now that I gave a big overview of what AI means and what we are doing with AI, I'm gonna tell a little bit about my story and how we are bringing technology to Latin America. This was like many years ago when I first presented in a global stage the role of bringing innovation to radiation oncology in Latin America. So in my country, Brazil, we have SUS. SUS is a public system that covers, it's free and cover universally all population of Brazil. So everybody has access to SUS, and it's free of charge. So SUS has a main databases where we collect information. Majorly, what I want to highlight here, information on all hospitals affiliated to SUS, and also all ambulatory care or ambulatory system access to SUS. So on those databases, we'll have data of basic patients' demographics, patients' outcomes, patients' mortality, and many other information. We also have a second database, which is a big database of the state of São Paulo, which is a prospective public cancer database from Hospital Registry. It includes about 76 hospitals, about 1,100,000 patients. And we have resources for epidemiology and AI-based research. With that in mind, there is a big investment of people and money to generate a national database, a database that we can put all this information together, including basic information from our population, age, gender, ethnicity, and location, together with more complex as diagnosis, treatment facilities, and outcomes. With that in mind, we are developing a data lake that is already in use, and we can learn from our own data, and we can use those learnings to improve care and to shape policy. In addition to that, there's also innovation being used, or automation with AI being used to improve patient experience. And here I will give you an example of what has been deployed on one of the largest cancer centers in São Paulo in Latin America. And the name of the tool is ERA. So ERA is presented now in the largest hospital complex in Latin America, and is reducing waiting time by 75%. So before this automation system, patient would wait about 30 minutes in a line before being seen by a secretary that will organize the care of the day. Now there is no more waiting line, and instead of like taking 34 minutes, it takes about 1 minute. And how ERA works is an automation logic robot process that reduces the numbers of clicks needed for input and output. So in the past, patients would need to line up and then wait their time to speak with the receptionist, to give their documents, and then to find all their appointments and where they need to go on that day on this large hospital. With this new system, there is multiple screens. The patient will just add his ID. The ID will show whatever is booked for that day is already connected to a printer. The printer will print the labels and automatically will create the patient file in the electronic medical record system, and then the patient could go straight to their clinic unit. The process also helps physicians because instead of multiple clicks to open and close system, now they use a face ID recognition, and with voice recognition and language processing, they can also dictate notes that are automated, formatted by the computer system. So there is a big move from everything being paper to now everything being electronic, and all the information being automated and organized in a file. So that's easily how the interface could look like. So you can add the ID, you confirm your data, and then you can order imagings, you can order whatever is needed, and you can input more information if needed. ERA also has the potential with AI to tell us if an ordered exam is correct and if it is necessary, and also send a message when the exam are done. So that makes redundant work less frequent, and also makes care more available and fast. So based on all that I showed to you, in the last 2 years with the Brazilian team, we were able to publish more than 20 manuscripts. Now it's about 28. We secured about $3.5 million grant for people in the ground. So for the Brazilian team, not for the international team. And we are also looking for a potential $15 million donation. So the goal is that we can create a Canadian unit for Latin America study, bilateral learning with our colleagues. We can leverage AI for better understanding cancer care, health system, and disparities. We can foster local expertise. We can promote innovation, And also very important, we can train the next generation. And if you want to learn a little bit more about training next generation, this is a couple of studies that our team has published at Nature and other journals on how to train and what is needed for the next generation. But let's talk why AI matters in medical education. As I stated on the beginning of this talk, health data is becoming more advanced. We are now moving from simple calculations to clinical decision support systems that are complex, and they use AI to provide individualized lifetime risk for our patients and our physicians. So, for instance, we now have these powerful models like ChatGPT by OpenAI, MedPalm or Gemini by Google, HealthScribe by Amazon, and there are other many tools on the rise. So we need to understand that. We should fundamentally rethink how we train physicians and how we train the next generation of healthcare professionals, because our career is not straight anymore. It's very complex, it's interconnected, and it's changing all the time. I believe that the healthcare professional of the future should be able to explain to patients the benefits and limitations of management plans guided by artificial intelligence, because I don't think that healthcare professionals will be the only professionals holding knowledge in the future. So knowledge will be available to everyone. So our main task will be to facilitate care. And if you want to facilitate care, you need to understand how AI works and how AI is taking decision and supporting next steps for our patient care. So I do recommend that we change the curriculum on healthcare graduations. And now we should be covering basics of programming, statistics, data stewardship, and also ethical and legal dimensions of applying technology to healthcare. This is a study that was performed here in Canada, where we tried to summarize what needs to be taught and what needs to be learned by trainees jumping on AI. So as you can see here, the major focus was intro and biostatistics, machine learning application, literature examples, and then case studies and programming. I think these are keys for us to understand the future and how we can keep leading the changes that are happening in oncology. This is another study by our team that we were looking for AI in oncology, the resident perspective based on their gender and based on their tech literacy. So what we found is that there is a need for inclusive tech education to promote diversity in artificial intelligence medical application and in residency applicating cohorts. So what we see here on the perspective of our trainees here in Canada is that if you can see here, the blue line show that they agree or strongly agree. So if you go on the top 5, majority of the residents agreed or strongly agreed that AI will become common in the future. AI will improve medicine. AI will optimize physician work. AI will cause more benefits than harm, and that the specialty that they are pursuing will be affected by AI. So people are aware that artificial intelligence is changing our profession and is changing with more benefits than harm. There's also, if you look here on the right side, again, blue is agree, and a strong blue is strong agree. So what are the educational resources that people are looking? So number one, they will use artificial intelligence during their medical career. And I can see that in clinic, most of the time, young physicians or young healthcare professionals, they are looking at ChatGPT or any other AI tools to gather information when they question something or when they don't know the answer. People understand that they will need to understand AI during their career. Um, they would like to learn more about the AI. They would love to formally be taught by AI. And they also understand that programming or mathematics is a barrier for their understanding on the basic application of AI. So the approach that we suggested is that AI has to be integrated into education in healthcare. And for that, we should be adding fundamentals of R and Python, statistics, data collection, foundations of probability, enhancement of probability reasoning, evaluation of AI algorithm, integration of algorithm outputs, in-depth concepts, AI concepts discussion, legal issues, and critical evaluation of AI research. There is this very interesting study that kind of like prove our assumptions. So this study compared case-based learning using Watson for oncology, so a previous AI model, and the traditional method where teaching directly undergrad students. So Watson for oncology is a decision-making system generated by AI. So what the study showed is that the group that used Watson for oncology had significant higher scores in independent learning, knowledge mastery, learning interest, and participation and satisfaction. So what I can see here is that AI has the potential to make learning a better, more interesting, and more satisfactory task. We also did some study on the ChatGPT in medicine and how these are changing the future. So we put together a table where we believe there's an excellent use of ChatGPT, where is not recommended, where we need to be cautious about, and what is the future. So at this time, we can use potentially ChatGPT for templates for clinical notes and documentations, templates for administrative notes. We also can draft patient educational materials, but needs to be curated by healthcare professional. We can summarize a complex knowledge, and we can also use that for crafting a research document, for languaging revision and editing of a manuscript, and also helping us troubleshooting statistical and coding. We all know that ChatGPT is here and it's here for a stay. So this slide highlights that ChatGPT has already passed the USLME exams. And for most of the people, this is the most difficult exam in medicine. So ChatGPT was able to master it. And what that means, correct? So what does the practice of medicines will look in with AI in the future? What we need to know, what we can expect from the various AIs in the future, and what are the challenges and barrier. What the American society, the Canadian society, they all agree is that everybody is going to need training on AI, and digital literacy and competencies should be integrated into the formal curriculum. However, we are still facing a big divide. So this scoping review by Eric Topol and his team evaluated randomized clinical trials that assess artificial intelligence in clinical practice. And as you can see here, most of the studies were performed in Europe and North America. So leaving low and middle income country regions like South America, Africa, and Southeast Asia, again, not as part of the leading efforts of evaluating and applying AI to healthcare. So again, we need to be very cautious because the distribution is skewed, and we want to make sure that there is representation and there is data from all over the globe, so we decrease bias and we increase external validity of the algorithm's development. In the end, this is majorly a culture of innovation. So we need to foster culture of innovation in our environment, including our own hospital, region, city, state, country, and etc. And for that, we need networking, we need attitude, collaboration, willingness to take risk, investment, and support. My view is that human intelligence, reach a peak. So machines, because of the amount of information that they have access and the amount of information that they can learn, they can easily become more intelligent than us, and they can easily peak faster and higher than us humans. However, humans plus the machines, we can become smarter, and then we can become more humane. So meaning that we can leave the complex and boring tasks to the computer, and that will liberate time for us to focus on our patients, to focus on promoting connection, empathy, and emphasizing care that really matters. Finally, what I believe for future is that we must generate high quality evidence based on randomized trial prospective studies to prove AI clinical benefit. And for those who are afraid of AI, I would challenging you and say that there is no AI without human on the workforce. So we are going to be around, we are going to be available. It is just a matter of what will be our key role in the future. So finally, I believe that there are keys for successfully driving digital transformation, and that is focusing on what is achievable, innovate towards a specific goal of your place or your region, empower and mobilize people and teams, test, 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 test. So this is a multidisciplinary effort, a collaboration between oncologists, data scientists, technologists, is vital for the success of AI implementation. And in addition to that, collaboration among different institutions, countries, regions is key for the future. So I really appreciate, I was told I had 40 to 45 minutes. So thank you. I'm happy to take questions. Okay, so first, if you have any questions, so feel free to send. Let me take a look here on the chat.
Yes, Dr. Morez. So I can help start reading the questions that have been left in the chat.
Thank you.
So we'll start with the first one. Can you give examples of some AI tools being used in oncology?
Oh, there is multiple. So from risk prediction to early diagnosis to treatment decision making, and also for toxicity prediction and for follow-up. So let's start. There is multiple studies looking into imaging patterns for breast early diagnosis, and those models are deployed and are being used in many clinics around the world. There's also algorithms using for auto planning. Is actually here in Canada, they are using in clinic, and there's also a large study now running with King's College and MD Anderson in low and middle income country testing auto planning and remote planning. We also have AI for drug discovery. So there's new platforms applying algorithm for discovering new drugs and developing new drugs. I can also give you an example of clinical decision support tools. For instance, there's Glass Health, which is a tool that you can describe your patient information, and that will help you with differential diagnosis, potential treatment, etc. Open Evidence, which use AI to help you answer clinical questions. Yeah, these are a couple, like 5 or 6 like examples that came to my mind.
Great, thank you. Next question is, you mentioned that people are afraid of AI, afraid that AI can replace them. Given AI knowledge of NCCN guidelines, will oncologists be needed in the future? Will residents need to be trained in the same way?
I would say that residents, they need to be trained in a different way. So as I want to highlight, it's key for us to understand how technology and AI work so we can integrate that on our daily basis in our future. So the way that we are trained must change. I personally, I don't think we need to be exposed to like hundreds to thousands of cases anymore, as they used to say in the past. So the best training program is the program that has the biggest volume of patients, because in the past that was needed because you need to develop your own like experience and like encyclopedia knowledge in your brain. But now with access to information and with AI, if you are trained in an institution that you're able to see a good number of all the most important cases, the most rare or support that you need, you will be able to get those support through clinical decision tools and through like technology. So I think that's number one. I believe that oncologists will be needed in the future, but being honest, I believe that our role will change. We're going to be more working as facilitator of care in multiple instances, but there is places that technology will take longer to be adapted and to be implemented, and then the role of oncologists will not change for many years. So I still believe that training is super important. We need to shape how we train, and the future is still bright. It's just like a different role and different potential applications of our knowledge.
Amazing, thank you. Next is, how would you advise someone to start radiomics study in a radiotherapy setup?
Perfect. Yeah, I think like the key for you to have a successful unit for doing research in radiomics is majorly partnering or playing as a team member with people from radiology and also people from computing sciences. So the way that we build around here is that we have a core team from researchers from radiology, researchers from computing science, and then researchers from medical physics. Because majorly what you need to do is first create the infrastructure to create a number of people that has interest and has knowledge, and three, create a pipeline so you can start following the rules that you generate, so you can bring images and then you can start extracting information to support your next step. So it's not easy. It's based on developing a group of people with established a pipeline of rules and next steps.
Okay, thank you so much. And next is, how can AI systems in oncology be designed to adapt dynamically to evolving clinical guidelines and protocols?
So it's a great question. So the way that we are like people are doing that, and the way that we can do that is actually, instead of like working on these big LLMs like ChatGPT, so people are creating their own, like people, I mean companies are creating their own smaller ChatGPT or LLM. So we call it like fine-tuned LLM, where you can bring a huge amount of information and you can customize on where the LLM is learning and where and then where their output is coming from. So you change the input. So actually now you have the potential to use available technology and to put inside all the information from your company or from your hospital and from your society. So you can kind of fine tune the information and making sure that when the LLM is generating the output or the response, they will look at the documents that you are highlighting. And that's what I was discussing when I said when ASCO, the American Society of Clinical Oncology, partnered with Gemini, with Google, The idea behind that is that they are using a specific fine-tuned LLM that will only look at all ASCO publications and guidelines when providing you a response or output. So the way of doing this is through fine-tuning a smaller LLM.
Great, thank you. And next is how can AI-based treatment planning systems optimize beam arrangements and dose distributions to minimize radiation exposure to organs at risk while maintaining tumor coverage and adapting to individual patient anatomy and clinical constraints?
Yeah, that's like a 4 hours like mini course by a medical physicist. It's outside my main scope, but like what majorly we do is for auto planning the application of AI. So learning from previous experience and learning from a big databases of cases, AI start to learn how humans in the past arrange the beans, how humans in the past like the dose distribution, how the beans were arranged to improve coverage and to decrease exposure to organs at risk. So in the future, after you build this big knowledge, as soon as you have a new case, the algorithm based on previous experience will arrange the beans in the best possible way, while it will maintain all the targets that in the past you have taught them that were the best targets, and also will do the best to reduce radiation to organs at risk. So it's majorly trying to mimic what you have or your institution or whatever database it was trained have been doing in the past. So this is majorly how it works.
Amazing, thank you. And our last question is, can we trust AI in difficult cases such as breast cancer treatment planning, where minimizing toxicity to the heart is critical?
So just there was a quick question before, like you said, need to bend the knee of technology for impact. Does this AI can be used as a tool? So no, we don't need to adapt to it. So we need to augment our work. We need to learn how to work together. So what I mean by that need to bend the knee of the technology is that we still are the most important part of the care. We should not let technology or AI become greater than us. So meaning that we need to bring AI and adapt AI to our pipeline or to our workflow. So the last one, sorry, it was, can we trust AI in difficult cases like breast cancer treatment planning or minimizing toxicity? I believe yes. So we are building algorithms. We are building AI planning algorithms that will help us to have very safe plans that minimize harm and increase coverage. However, it will be always the physician and the team responsibility to review those plans and to approve those plans. So in the end of the day, it doesn't matter if the AI planned it or not. Who is responsible is the human. Because if something goes wrong, they are not gonna sue a computer. They're gonna sue us. They're gonna sue you. So meaning that if you don't like the plan, if you don't think AI is doing enough or a good enough job, you should reject that plan and then getting a manual or human-based plan. So in the end of the day, remember, AI is a tool potentially applied to augment or to make our work better or faster or improve our work. However, when it's not doing it, we should reject.
Wonderful. Thank you so much, Dr. Morez. Incredible lecture, and we're getting lots of comments of people saying how much they enjoyed your lecture.
Thank you. I really appreciate.
Okay, everybody, so the survey link has been sent out. I am getting responses, so it should be working. And we will get ready for the next lecture. So I would love to introduce Dr. Daco. Hi, Dr. Daco. Welcome.
How you guys doing? Right. So you want me to go ahead and get started?
Yes, whenever you're ready.
Got it, got it, got it. Okay. All right. Uh, all right. Can you guys see my screen?
Yes.
Okay. So, um, my lecture is really a discussion of a recent paper that we just got accepted. Myself, Fabio, Will, and a bunch of other authors. And it's really a follow-up to Dr. Morales' lecture. Um, I would have shared the actual paper with you guys, but the publishers don't want us to share it yet because the article is not online yet. But this is a paper from Lancet Oncology Commission that we all a part of, specifically talking about digital health and AI innovations for oncology in Latin America and Sub-Saharan Africa. But this paper is focused on Sub-Saharan Africa. And so hopefully we can have a good conversation. Again, a lot of it is going to build on the concepts that have been discussed with more directed conversations towards Africa. And so my name is Farouk Dako. I'm an associate professor of radiology at UPenn, and I do various things. Um, I guess one disclosure is I'm one of the board of directors for Rad Aid International, which is an NGO that does work that's pertinent to some of our conversations. And so, just as an introduction, as most of us know, there's a rising cancer burden across Africa. In addition to that, there's a severe workforce shortage for various reasons. The WHO projects a deficit of about 6.1 million healthcare workers across 47 countries in the African region by 2030 if current trends persist. And so, as was mentioned, we're now in a state of desperation where we're looking for whatever can improve the current diagnostic and treatment capacities, in addition to trying to train healthcare workers as fast as we can. We understand that we can't do that fast enough. And so digital health, including AI, is now all of a sudden something that we're looking forward and we're looking for answers to solve these problems that we're in. And it's also recognized that, this represents a unique opportunity for us to leapfrog a lot of the barriers we have to healthcare delivery in the sub-Saharan setting. And so just a few or an important slide here is just the key concepts, right? So we talk about digital health and there's various definitions, which I'm not going to go into, but really just to emphasize the different components to it, right? So one component is telemedicine, right? So the ability to provide care to people who are not right in front of you using internet and various technologies. Then you have mobile health or mHealth, so things like mobile apps in which you can collect information from people remotely, right? And sort of make decisions based on that information, as well as things like wearable devices. So these wearable devices are also proliferating. It's as simple as your Apple Watch, for example, that can monitor your vitals in real time and be able to transmit this back to your healthcare provider to be able to gather data about you in a longitudinal fashion, as well as make acute decisions. And then we have our clinical information systems, right? So this is also important, right? So things like electronic health records, PACS systems for imaging. And then we're now in the era of big data, right? So, and this has an overlap with artificial intelligence, which typically requires a lot of data. But we're in the era of precision medicine where we are incorporating large amounts of data, like I just said, collected from things like mHealth, and integrating that data using integrated networks to be able to make personalized decisions about individuals, right? So this era of precision oncology, for which digital health is a strong precursor for. And so, what is the digital landscape in sub-Saharan Africa, based on our paper, right? So there's good news, right? So we know that there's extensive mobile broadband coverage across African countries now. As of 2020, about 81%, right? We know from other industries like fintech that we now have a lot of African societies, countries that are cashless, right? Where transactions are made on your phone to pay people to access your bank accounts and things like that. And so this gives us a lot of hope that what we've seen in fintech can be leveraged in health tech as well. We know that a lot of African countries are coming up with electronic health strategies. One of the concerns that we're seeing is that it's quite heterogeneous. There's a need for more regional approaches to be able to coordinate across countries, because without that, there's a risk for what they call e-chaos, where a lot of digital health solutions are being integrated in various countries, but they're really not in coordination with each other, and they're really not uh, speaking to each other. And so, despite the potential progress, fragmented systems, which is typically uh, due to the fact that a lot of these things are supported by vertical investments, right? So we're still pretty much dependent on grant support that supports specific disease processes, right? And so you have one digital health solution for a grant that's for malaria. We have a different digital health solution for a grant for tuberculosis, and you get the point. And so we're seeing that a lot of these countries might have various solutions, but there's a lack of integration, which limits the ability to scale these things to really improve population health. And so some of the examples that we talk about in the paper from the review of the literature is in telemedicine. For example, we're seeing examples from countries like Uganda, Tanzania, and Zambia, where telemedicine is used for uh, remote consultation. Again, I know these things are present in virtually every country, but we can only report based on things that are published in the literature. Okay. They've been examples in South Africa for randomized controlled trials where telehealth is used for depression treatment. However, what we see from the literature is that there's still challenges in infrastructure, right? Training, as was mentioned, there's a huge need to train our workers for the technology of today and tomorrow, which most people don't really have that basic digital health training. And we also are seeing that there's an issue of trust, right? So not everyone is trusting of these technologies, and people are used to a certain way of receiving care, perhaps face to face, being able to see their physician and build a longitudinal trust. And so not everyone is adapting these telemedicine solutions just based on lack of trust, again, from the patients, but also from some administrators as well. Not everybody wants to invest in that. But what we've seen from the literature is one thing for sure: telemedicine can expand oncology services to the most remote and underserved areas. What about mHealth, right? So there are examples in the literature of mHealth being used for vaccine reminders and maternal health to be able to get feedback from the moms about about their prenatal care and things like that. We've seen mHealth being used in chronic disease management, especially for things like high blood pressure management and things like that, where you can, send in your blood pressure um, measurements remotely, and doctors and nurses and your healthcare workers could make decisions without actually being there next to you. One of the areas for that's an untapped potential is we see that when we really survey people and look at the literature, almost everybody says that they use some form of M health, like mobile phones for as part of their treatment plans, and so there's an opportunity there to formalize existing technologies to be used at scale, right? So it's like, yeah, in our hospital, every now and then, we call patients and we text patients, but can we really integrate that, the electronic medical records to send in patients automated text reminders, and having patients routinely sending information as well through the cell phone. And so there is this untapped potential for structured interventions in the M health setting in sub-Saharan Africa. Electronic health records is it's a foundational piece that's needed for integrated care, for and for research, right? It is also one of the most expensive components, right? Because it requires consistent power, right? It requires training of your whole workforce to go from paper records to being able to type things in the computer, to be able to retrieve data. It does require the most amount of maintenance, right? So so you need power, you need internet, right? And so that is an area for that is not, it's not the lowest hanging fruit, but it's something that ultimately needs to be present to be able to maximize the potential of your telemedicine and your M health and your AI, right? This is what is really going to form the basis for um, Africa making that jump from from the era of analog to digital transformation of oncology care. And so there's a huge push from the WHO for coordinated platforms to be able to feed into a central electronic healthcare record. So what about AI and big data, right? So we looked at the literature and we found that, there's a lot of use of AI and big data in multiple diseases, right? So from things like tuberculosis screening, we know that's been a big one, using AI for chest X-ray interpretations to be able to triage patients with potential TB, even in the absence of a radiologist. But we've also seen the use of AI for predictive analytics, things like population health research, for things like Down syndrome and schistosomiasis. Also things like COVID-19 modeling, malaria prediction, just based on integration of multiple data sources to be able to say, hey, this is where we might be expecting malaria in these months out of the year. But one of the big challenges that we see in Africa is that there is lack of our own local data and our own local computing infrastructure. But despite that, AI tools have already shown some success even in the Africa setting, with a caveat that more diverse data and training are needed. And so this is just something that we looked into and in the paper to see, how can we find a proxy to measure AI capacity in sub-Saharan Africa? And so one proxy was to say, okay, what are the original research that's coming out of sub-Saharan Africa about AI in oncology care, right? And so this just shows you the figure to your left shows you the longitudinal trend in AI. This is original AI research in oncology, all right? And it shows that it's increasing over time. But it also shows that within Africa, there's significant regional uh, variability. As we can see, most of it is coming out of Southern Africa, and followed by East Africa, all right? And this just shows you a more spatial distribution of where the actual papers have been coming out from, right? So South Africa, right? Some countries in East Africa, Nigeria, Ghana. And so there's still areas in Africa where we literally have no data about AI in oncology care, right? And so this highlights both the potential, the progress being made, as well as the unequalness of the progress being made. This is more AI in action. This is a case study, unpublished, but it's a case original case study we use in the article coming out soon. As was mentioned, this is AI used for radiation planning, contouring. And it showed that, this is a study that came out of Lagos University Teaching Hospital in Nigeria. And it showed that the oncologists that use AI spent less time um, uh, contouring versus the traditional smart segmentation, right? And so this just demonstrates that, again, despite all the barriers that we've seen, there is a uh, uh, potential for high impact, right? Especially in places like sub-Saharan Africa, where, as we mentioned, the workforce shortage is severe, right? So using a tool like this to reduce contouring time demonstrated more patient throughput, and also importantly, improved job satisfaction by the radiation oncologist. And this is something that we need to also take into account to help reduce the brain drain, right? It's how can we improve the job satisfaction of whatever workforce that we have left in sub-Saharan Africa. So not only are the jobs easier and more productive, but they're also more satisfied. This is another case study that we've talked about in the paper, just demonstrating an example of AI workforce development. So this is a program that's been going on for a couple of years, and I'm a part of. Is led by one of our colleagues, Udona Anazodo, who is a medical physicist and global health expert at the University of Toronto. And this is showing you how we've been able to train some AI experts over the last couple of years, right? Using this teach, try, use approach, right? Where, we do workshops, things like this, foundational courses to learn, but quickly follow that by hackathons, right? So people need to get practical experiences right away, especially as adult learners, right? This is something that we typically lack in the sub-Saharan setting, where there's a lot of emphasis on the theoretical component, but not enough on the practical component. And so we teach, we quickly try, right? Have teams working together, and then eventually we have teams at the end of the process do a practicum, build their own state-of-the-art AI models. In this particular case, our trainees worked on the BRATS Africa Challenge, which is a huge radiology challenge that came out of my University of Pennsylvania, supported by RSNA, and get these trainees participating with their colleagues from around the world as soon as possible, and competing with them and learning from them. And this just shows you some of the numbers um, over the years from 2023 to 2024. You can see the dramatic increase in applicants. We were able to increase capacity and take in more trainees, and include more countries. Importantly, creating these multidisciplinary teams of not just training physicians or physicists, right? But including radiation technologists, you know, all kinds of interdisciplinary teams that you expect to be working on oncology patients, training them together to build models and understand AI, and ultimately become trainers that train the next generation of trainees, which, as we know, teaching is part of learning, right? Teaching is part of how you hone in on your skills and you become even more confident in what you've learned. And so these are just some numbers, right? So of the Spark training. So it's a 7-week Pan-African neuroimaging AI course, 300 trainees from 23 countries. The pair-led case-based model. They participated in BRATS Africa and a ton of other open source competitions and creation of models. And this is just an example that we show of how to scale AI literacy while grounding it in the local needs, right? So a lot of what the projects that these participants have worked on are projects that are tackling local problems that that they see. And so, I've given you some examples of, AI already being used in a clinical setting in sub-Saharan Africa, um, uh, efforts to increase AI workforce that we're undergoing. But, there's still these barriers to digital health, which digital health is a strong precursor for artificial intelligence, right? You can't truly say you're going to incorporate AI into your any practice if you're not also undergoing a digital transformation at the same time or prior to that. And so some things that we just need to work on. One is financial, right? So I think that almost like the elephant in the room is that, no matter what we do, all these lectures and grants and stuff, if our governments are still not spending enough on health, then we probably will not be able to make sustainable progress, right? So under 5% of GDP is spent on health in most countries in Africa, despite efforts to, from things like the Abuja Declaration and things like that have urged countries to spend up to 15% of their GDP on health. This really isn't happening. We also need policies, right? So there really aren't policies from a national level at least being enforced that's tell hospital systems and to say, hey, you need to store your patient data for 5 years or 10 years, right? These are policies we have. For example, in the US, most states, you can have a diagnostic center or a hospital if you don't have the capacity to store patient data, imaging data for 5 to 10 years, right? It's a national policy. And so these policies are needed to bring about the digital transformation, because digital transformation has upfront costs, even though we believe ultimately it is cheaper to go digital than to continue to use paper. In addition to enforcing these policies, we also need to have policies for data protection, right? So, from my experience, right, in a lot of African countries, there's either no policy or the policies are not being enforced, right? To make sure that patients are being protected, and to make sure that there's a equitable use of patient data that is also resulting in improved capacity in these regions. And then there are technical limitations like we've talked about, right? You can expect a hospital system to completely go digital if they don't if there's not an enabling environment for that to happen, right? So we must talk about the things like, the frequent power outages and what that would do if you have a digital infrastructure, right? We must talk about things like, lack of continuous internet connectivity, right? And and things like that, which are enablers to have to bring about digital transformation. And then social cultural, right? No, in a as part of change management, right? You cannot make change without dealing with the social cultural components, right? And so you have to bring about some sort of digital literacy, some sort of core digital literacy, not just of your clinicians, but of your administrators, of your leaders, right? And also eventually of your population to be able to accept these new um, uh, digital solutions and participate in them, right? And to reduce technology mistrust, right? And so these are all things that we have found to be barriers to digital health transformation. And so some strategic recommendations, like I said, we must, as difficult as it is, embark in some conversations with our leaders about the need to invest in infrastructure, not just for the short term, but for the long term. We in Sub-Saharan Africa have this opportunity as well to design our own infrastructure, not to mirror what it is in Western countries or other countries, but to make it interoperable, right? To build single infrastructures that can do multiple different things rather than having 5 or 10 different things as we have in the West that now have to talk to each other. And so we have an opportunity to design our own infrastructure to meet the needs and to be responsive to our own local environment, right? And we must build inclusive digital literacy programs, right? These are these are things that again might seem trivial, but are actually critical enablers to be able to use uh, digital infrastructure. We must have regional policies for data sharing, right? It's we we must learn from other mistakes in the sub-Saharan African region where it's more difficult to go from one African country to another African country versus going to Asia or like Europe, right? So we must have regional policies, right, to be able to leverage each other's strengths and to be able to build together, right, and to be able to speak to one another. Um, and ultimately have regional centers for excellence that specialize in different things that can help each other uh, grow together. Public-private partnerships is something we've seen to be one of the most efficient models in the world, but also in the sub-Saharan African setting in particular, right? Where some would say we just can't rely on government, right? We can't change government overnight, but we know that when we include a private incentive, things tend to work better. Things tend to be more efficient and meet the needs of people because there is actual people behind it that are trying to run a business. And so ultimately, we must believe that Africa can leapfrog other regions of the world if it has the right investment, governance, and workforce readiness. And so this is just a illustration. This is something called a Global Digital Health Monitor. You can look it up. You can Google it. It's from the WHO. It's an interactive tool that can tell you regions and countries' digital readiness, sort of digital ecosystem, right? And as you can see, Africa as a whole, right, we're still in the phase 3 and 2 of having an enabling digital environment, right? So these are things that I just talked about. So having the right policy, having the right infrastructure, right? And so, these are tools we can use when interacting with our funders, our government officials to say, hey, we can't do X, Y, and Z that you're talking about because we don't have the right enabling environment, right? And so, this is just an interactive visual tool to really summarize a lot of what I've been saying. And so, in conclusion of this particular paper, digital health and AI can revolutionize oncology care in sub-Saharan Africa. Equity, sustainability, and data diversity are key. And Africa has an opportunity to be leaders in this space and not just adopt existing solutions. And also, it's important for us to project this when we talk to our collaborators that this moment is not just for Africa, but it's for global cancer care, right? And so, as an example, you can't make this leap into precision medicine if you don't have data from around the world. And Africa has the opportunity to contribute to data diversity that would help solve oncological questions around the world, but it needs an enabling environment to be able to make this digital transformation. And so thank you very much for your time. I'm happy to take any questions.
Thank you very much, Dr. Daco, for a great lecture. We have a few questions whenever you're ready. So the first one is, it's amazing to see the extent of mobile broadband coverage. Does this primarily reflect access to basic mobile phones, or are we seeing widespread use of smartphones that can support AI tools and digital health applications?
Yeah, so these are not smartphone specific. This is just the presence of mobile broadband coverage. And so not everyone is using a smartphone, but they still can do things like mobile banking, even on a non-smartphone. But yes, there's definitely some limitations based on the actual technology you have to tap into the mobile broadband.
Got it. Thank you. The next question is, given the adoption of AI in clinical settings like radiology in hospitals in Nigeria, how is this reshaping the training needs for radiology residents? Will the role of radiologists change significantly in the future, or is this the core of their expertise, which is still essential?
Yeah, so again, I think that's a great question, right? So radiology, as was mentioned in the last lecture, we ultimately have to change the way we train, right? You know, there's a there used to be a scare hype that, AI was going to replace radiologists. I think now we've all settled on the fact that radiologists using AI are going to replace radiologists not using AI. And you can extrapolate this to other specialties as well. And so, yes, I think the way we train has to change. AI literacy has to be included in our training of our radiologists, and we have to allow them to reimagine what else they can do, right? Um, in places like sub-Saharan Africa, we're not even having a conversation because of the workforce. The workforce shortage is so great that it's not really a question of replacing, but it's really just a question of the current radiologist being able to do more with their fixed numbers, right? And so we think AI is going to augment, expand the current diagnostic capacity, right? So um, I'll give you like a case example, right? In one of the places that we installed AI software in Guyana, but also in Nigeria. But in Guyana specifically, let's say there were 3,000 chest X-rays being performed. Most of them were never being interpreted by a radiologist. But we introduced an AI software that basically only was able to identify the positive cases, and then those positive cases were triaged to the radiologists. And so it can make us more efficient in our approaches, right? The radiologists were never going to be able to read all of those studies, but at least if you have them focus on the studies that AI has said, hey, there might be something going on here, then they can be more efficient as a healthcare system. And so I think radiologists and oncologists and medical physicists and therapists are all going to work differently with the use of AI. We have to be humble in the fact that we don't know exactly what it's going to look like when it's all said and done, because the technology continues to rapidly evolve. But we do know that we have to be ready for it.
Definitely. So our third question is, in medical applications of AI like neural network predictions, how do we calculate and interpret errors? And since predictions can't be 100% accurate, what methods could we use to reduce these errors and ensure greater reliability and clinical safety?
Yeah, that's a good question. I just want to make sure I'm understanding it. So the question is saying, AI cannot be 100% correct. What methods can we use to reduce or correct these errors? Sure, sure, sure. So that's a great question, right? First of all, we need to be humble with the fact that, human beings have never been 100% uh, correct, right? So we need to start with that sort of frame, that sort of understanding, right? But for AI, it's important to one, do your local validation before widespread use, regardless of how well it's performed in a different setting, right? So you have to have we call it a phased introduction, but you have to have a time in which maybe retrospectively AI is used to analyze some data, and then you, the expert, sees how it does. Is it acceptable, right? And then you can start to use it prospectively. But even after you start to use it prospectively, you must have QA, QI systems in place to continuously monitor its performance, because we know there's something called algorithmic drift, in which it can actually change over time. We don't know. We don't really have long-term data on AI over 10 years. And so we must have systems in place to see how AI's performance is changing over time. Is it getting better? Is it getting worse? And we must be ready to intervene um, if it's not going the way it is. And so yes, um, those are some methods that we can use to improve its reliability and safety, is continuous quality assurance and quality improvement.
Sounds good. The next question, can IoT be used in oncology and how can it help improve cancer care? And if yes, what are some examples?
Yeah. What is IoT? What's that?
Internet of Things.
Okay. Um, for sure, I think Fabio has, I think Fabio touched on that, right? Where, I think the biggest resource for AI, including, generative AI, large language models, is being a great like reference material. And so, um, I think it can help with this idea of task shifting, right? Where, you didn't have to have this vast amount of knowledge. You don't have to have this vast amount of knowledge anymore to do certain tasks. You have, your Internet of Things right there as a reference material to be able to take on the tasks that were probably seen as above your training grade, right? And so I think that's one of the exciting things about it, is this idea that we can all do more. We can all enhance ourselves. And so in oncology care, all of a sudden, community health worker plus, AI augmentation could be doing things that maybe previously only a nurse can do in that setting. And this is this is particularly important in areas of workforce shortage, like we talked about in sub-Saharan Africa.
Definitely. So our last question is, most countries have different policies on AI, and these policies may hinder the developers. So specifically, how do we as developers in Africa go about this?
Yeah. So we've seen this to be a true issue, right? Like, this is actually a practical thing that we're seeing, right? Especially as it pertains to data storage, data sharing, right? So not every country would allow medical data to be in clouds outside of the country. Some of the countries do. Um, most countries don't have a strong policy. And so I think, like I said, that's why there's need for regional collaborations, and there's need to not just replicate policies from like the EU or the US, but rather to create our own policies that are unique to our own to our own problems. And so, I think we as researchers need to educate our policymakers about these issues. We need to understand that if we don't do it, nobody else will, and we do have the power to lead these conversations.
Great. I think that's a great note to end on, Dr. Dacko. Thank you again for a great lecture and Q&A discussion, as well as everyone's participation. If we don't have any other questions, I think we can go ahead and conclude today's session.
Thanks, guys.